And when we decide to control high blood pressure, it looks like we require to learn beyond blood pressure readings alone. And blood pressure mediated target organ damage evaluation becomes an important aspect of care of patients with hypertension. We could not have had a better person to deal with this topic, Dr. PC Manoria from Bhopal, a mentor of mine in the past and also a very good friend. And he's going to discuss how he wants to evaluate in the modern times the target organ evaluation in a patient with hypertension. Dr. Manoria, please.
Are you able to hear me?
Yep,
Yes.
go ahead, sir. Thank you.
At the outset, I'd like to thank the API Karnataka chapter for inviting me to this wonderful program on World Hypertension Day, Dr. Sangram, Dr. Murli Mohan, and other dignitaries. So for the next 20 minutes or so, I'll be talking on hypertension-mediated organ disease, which is commonly termed as HMOD. The last couple of years has witnessed spectacular advances in the field of HMOD, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. When we look at the heart, all of us know HFpEF is not uncommon in hypertensive patients, and we have SGLT2 inhibitors as class 1 recommendation for treatment of HFpEF. And very exciting data has emerged from injectable semaglutide in the HFpEF trial, not only improving the quality of life, the walking distance, but also cardiovascular outcome. So in times to come, I'm sure injectable semaglutide will also emerge as a new drug for treatment of HFpEF. Of course, HFrEF is uncommon in hypertension, usually occurs with CKD when there's volume overload, and then of course the usual drugs for HFrEF would apply. In the context of kidney, which is very, very important, and we like to learn from Dr. Kriplani, we have 3 revolutionary therapies. RAS blockers, all of us are aware of it. Then came SGLT2 inhibitors, and now we have the 3rd revolutionary therapy, non-steroidal MRAs, that is finerenone. And in recent past, the FLOW trial has been positive. So in times to come, you will also have GLP-1 receptor agonist semaglutide added to the pillars of CKD. In context of vein, we have lytic therapy for ischemic stroke, which is now being increasingly utilized in endovascular therapy. And in peripheral arterial disease and also stroke, a new concept of DPI, dual pathway inhibitor, aspirin plus rivaroxaban, particularly in peripheral arterial disease, has shown exciting results, and we have seen patients with threatening gangrene or intermittent claudication, there is immense benefit. Retinopathy is not my domain, so I'll not be much talking about it. Now, the message is very clear, and it's the old message, hypertension is a silent killer. But the message which has not percolated widely among the physicians and the practitioners is target organ involvement also continue to remain silent for a very, very long time. You may have severe CKD, you have left ventricular hypertrophy, another target organ damage, and you may be totally asymptomatic doing your routine work. And this slide must be widely disseminated, which shows asymptomatic organ damage. And one of the most important asymptomatic target organ damage is microalbuminuria. 30, 0 to 30 is normal, 30 to 300 is micro, and above 300 is macro. You may have microalbuminuria, you may have macroalbuminuria, you may not be symptomatic always. CKD, GFR less 30 to 60, ankle brachial index less than 0.9, carotid femoral pulse wave velocity more than 10 meters per second, carotid plaque or ECG or echo evidence of LVH, and a pulse pressure of more than 60 in elderly. So we must also realize that organ damage may also be totally asymptomatic, and that's why periodic evaluation of hypertensive patient is very, very important. When we are talking of the target organ damage or hypertensive mediated organic disease, we must adopt a holistic approach for treating hypertension, not only the office blood pressure, but the whole 24 hours blood pressure should be targeted, the nocturnal blood pressure, the blood pressure variability, the morning surges, all should be targeted. So when we talk of kidney in hypertension, this is very, very important organ which is affected by kidney, and a lot of things can be done. You can slow down the trajectory of CKD if you diagnose CKD at a very early stage, and we learn from Dr. Kripalani. Now, in the context of CD, what is very important to realize is that CKD is a progressive disease. We do not have any quick fix to reverse CKD. Once CKD sets in, it is a progressive disease. Unlike acute myocardial infarction, you can do a primary angioplasty and reverse the pathophysiological process. For CKD, we can only slow down the trajectory of CKD, slow down the declining EGFR, and postpone dialysis by 10 or 15 years. And we have three revolutionary therapies. RAS blockers, which came in 2001 after these landmark trials, IDNT renal, SGLT2 inhibitor, these three landmark trials, all of us are aware, and the non-steroidal MRAs, Fidelio, DKD, Figario, DKD, Fidelity. RAS blockers and SGLT can be utilized in both diabetic and non-diabetic CKD, but we have trials with phenomenon only in diabetic CKD, non-diabetic CKD, the trials are in progress. So the big message, rather the biggest message for HMOD kidney in hypertension is diagnose CKD at a very early stage for maximum benefit of the revolutionary therapies. And for this, you have to get an EGFR and albuminuria. And what is very important is that ACR is a better predictor of cardiovascular mortality across the full range of renal function. Here you can see UACR, even when it is a normal range, 0 to 30, you can see the hazard ratio at 30 is some 1.77. So even when it is in the normal range, your cardiovascular mortality hazard ratio at the margin of 30 is increased, and then it goes on increasing. Whereas with if you are estimating EGFR, only when the EGFR becomes less than 60, there's an increase in the cardiovascular mortality. So both these parameters must be evaluated, and all guidelines recommend that all these parameters must be, both these parameters must be evaluated. And you can see even if your EGFR is more than 90, and if you have macroalbuminuria, you fall in the high risk zone. So UACR is a biomarker not only for renal disease, but also for cardiovascular disease. Even in the microalbuminuria range, you can have a cardiovascular disease. In fact, microalbuminuria is a red signal for the cardiologist, a red flag for the cardiologist, and he must utilize all his therapy to minimize cardiovascular disease. And cardiovascular disease, all of us know, is a commonest cause of morbidity and mortality in CKD. But there's a lot of lack of awareness for doing UACR amongst the physicians, the practitioners, and this should be periodically done if you are diabetic, hypertensive, if you are in the microalbumin, maybe twice in a year. For several years, we have been chasing BP target, LDL target, glucose target, 90 pro BNP target, but time has come. You must also chase the UACR target. We must utilize UACR as a traditional target, both for cardiac as well as renal protection. And the goal is to reduce the UACR by more than 30% if it is more than 300. And this is a guideline based. And if it is reduced by more than 30%, you try to reduce it further. And these are the three established pillars of CKD, the RASI, the SGLT2 and MRAs. And now after the flow trial, which has been prematurely terminated, in times to come, you may have the fourth pillar with semaglutide. Heart in hypertension, heart again is a very important target organ which is afflicted by hypertension, and you can see you can have LVH, fibrosis, which I'll be talking about, diastolic dysfunction, HFpEF, HFrEF, or a CAD angina or acute myocardial infarction. Left ventricular hypertrophy in hypertension, the extent is predominantly related to the duration of hypertension, the level of increased blood pressure. Initially, it occurs as a compensatory process representing an adaptation to ventricular wall stress, but several other factors are involved besides the hypertension: increased sympathetic activity, RAS activation, salt intake, and some genetic predisposition. And if you have left ventricular hypertrophy, 2 to 4% higher risk of cardiovascular event, increased stroke, cognitive impairment, AF, ventricular arrhythmia, sudden cardiac death, diastolic dysfunction, HFpEF, and HFrEF, particularly of CKD. Regression of left ventricular hypertrophy, RAS blockers, ACE/ARB are more effective, and regression results in reduction in cardiovascular events, heart failure, AF, and it has a better prognosis. How do we evaluate? I think all of us are aware of it. ECG, echo, and these days LGCMR is used to detect fibrosis because a hypertrophic fibrotic ventricle is bad than a merely hypertrophic ventricle, as I'll be talking in a couple of minutes. Evaluation by ECG, I think all of us are aware of the voltage criteria. Sometimes you can use a non-voltage criteria, usual ECG. Sometimes you get low voltage in the limb leads, but LVH in the precordial leads because there is edema in the limb leads because of heart failure. So, and this again, sometimes people want to differentiate whether the ST changes in left ventricular hypertrophy is because of strain or is it because of a coronary artery disease. And these are some of the points. If you look at the J point, with a pressure over LVH, you can see the J point is depressed. Whereas in ischemic injury, J point is not depressed. ST segment is downsloping in left ventricular hypertrophy strain, is horizontal. T third wave inversion is asymmetrical. You can see this is asymmetrical, whereas a symmetrical terminal part of T overshoots in left ventricular strain, you can see, but this is isoelectric no overshoot. So these are some differences for those. Serrations in the upstroke of the QRS or downstroke is indicator of fibrosis, but this is not a very sensitive. It is LGECMR, which is a very sensitive test for fibrosis, and I'll be talking to you very shortly. Now, echocardiography, I think all of us are aware of. How do we make a diagnosis of left ventricular hypertrophy by LV mass, and I'm not going to detail. Now, what is important is whether you have a concentric hypertrophy, whether you have an eccentric hypertrophy. This has prognostic importance. Eccentric means your LV wall thickness is normal, but cavity size is increased, your LV mass is increased, and concentric means thickness is increased, cavity size may be decreased, and LV mass is increased. Now, this is important. Now, so if you have a concentric and dilated LV like this, the patient survival is worst. Compared to concentric without dilatation, comparatively better. And if you have an eccentric hypertrophy, if it is non-dilated, it's better than it is dilated. So that is the importance to differentiate these styles. And this is the usual picture. I think all of us are very familiar. Transmitral Doppler, I think all of us are also familiar about these patterns, the normal, the impaired relaxation, the restrictive pattern, and I'm not going into the details, and the E by E prime ratio more than 15 becomes abnormal. And this again summarizes the various echo features of diagnosing HFpEF, which means you have to have evidence of heart failure or structural heart disease, LVH, LA enlargement, or left atrial volume index, increase in BNP, more than 35 in sinus rhythm, or more than 125 NT-proBNP, and you can measure the left atrial volume index, E by prime ratio more than 14, pulmonary artery hypertension, left ventricular mass index, and tricuspid velocity increased. Now, this is a new concept. How do we evaluate fibrosis? Fibrosis in hypertensive patients occurs in the heart, it occurs in the left atrium, also in the vessel, the larger arteries as well as small, and I'll show you some data. Now, this is a slide which shows these small white dots. if you have a fibrosis in a hypertrophic ventricle, fibrosis predisposes the patient to development of heart failure. Fibrosis predisposes to the patient of developing ventricular arrhythmias. For example, in all hypertrophic ventricle, for example, HOCM, we look at the scarring or fibrosis by MR. More is the fibrosis, more are chances of ventricular arrhythmia and sudden cardiac death. In advanced centers who do aortic valve replacement, they always look at whether the hypertrophic ventricle of aortic stenosis also is fibrosis. If it is fibrosis, the result may be less optimum despite an excellent aortic valve replacement. Fibrosis also occurs in the left atrium. You can see these grades of fibrosis, and once the left atrial is fibrosed, this is an additional predisposition for development of atrial fibrillation. And if you have advanced fibrosis, grade C and D, the radiofrequency ablation which is done by the cardiologist, he always looks at left atrial fibrosis. If it is advanced, the probability of sustaining rhythm, sinus rhythm after RA ablation is very remote. So that is another applied importance. Fibrosis also occurs in the large vessel. I will talk. So another complication is angina. You can have an epicardial coronary artery disease, which is easily diagnosed. Microvascular has some problems. Angina could be due to increased demand or a combination. Now, this is the story of a 42 years old male, chest pain on exertion, TMT positive, angina in effort, coronary angiogram done at other hospital 2 years back, no CAD. He was dismissed. You don't have coronary artery disease. Somebody did a tell him and said, don't have any coronary artery disease, consult a gastroenterologist, consult a psychiatrist. Patient continue to have symptoms with no relief. He came to us, we did an angiogram, and you can see this dye is taking a lot of time to clear the epicardial arteries. And this is the simplest test for microvascular dysfunction. If you want to categorize or document microvascular dysfunction, you can do CFR. If CFR is less than that, 2, it becomes microvascular disease. But this is more expensive. You can get it from PET. So this is the simple way. The patient was prescribed anti-anginal drugs and he became real symptomatic. What is very important to remember is stress thallium will be normal in microvascular disease. The other importance of microvascular disease, which is not uncommon in hypertensive patients and also in diabetic, that if you perform an angioplasty and if a patient has distal microvascular disease, the results are going to be suboptimal, and paradoxically, it may also increase angina on some occasion. So detecting a microvascular disease in a patient with an epicardial disease is also important, and this is one of the simplest way. Otherwise, there are various tests to assess microvascular dysfunction. And as we said, CFR is the best, but that is not easily available in angina in hypertensive patient could be due to increased demand also, because the left ventricle is hypertrophy, there's increased demand, coronary may be normal, still you can have a positive test, or it could be increased oxygen demand due to hypertrophic ventricle. So sometimes you have a positive stress test, young patient, you find the angio is normal, the reason is this. Vasculopathy, which occurs in larger arteries, small arteries, we evaluate by pulse wave velocity, CIMT, ankle brachial index, and retinopathy for the ophthalmologist. You can calculate the pulse wave velocity, and this is to illustrate what happens if the pulse wave velocity is changed. Now, this is a compliant artery of a normal individual, pulse wave velocity 8 meters per second. The impulse goes from the heart to the aorta. You can see slowly when it goes from the heart towards the periphery. By the time it comes back slowly, the systole has finished and diastole has set in. And this increases the diastolic flow in the coronary arteries and is beneficial. But if you have an aortopathy, fibrosis is less compliant, the pulse wave velocity may increase, maybe 12 meters. What will happen? If you measure the pulse wave velocity, this comes back very quickly. So by the time it comes back, systole is already ongoing, and if this happens, it will increase the central systolic pressure, increase the LV afterload, increase pulsatile strain, plaque rupture may occur, no diastolic augmentation, and even decrease coronary filling. And aortic stiffness, all of us know, is an important risk prediction of cardiovascular events. And by periscope, you can find out all these parameters. It will give you brachial ankle pulse wave velocity. It will give you carotid femoral pulse wave. You can also have an idea about the central aortic pressure. And you can get all these very easily from the periscope. Ankle brachial index, all of us are familiar of. It is less than 0.90. This means peripheral arterial disease. If it is 1 to 1.4, if it is normal, but the patient has symptoms, do an exercise test. If it is borderline 0.91 to 0.9, borderline PAD, exercise ABI is recommended. CIMT is also performed by some, and the usual CIMT is 0.8. If it increases more than 1, it is a predictor of cardiovascular events. So you can see if it is more than 1, this is a high incidence of cardiovascular events. And both these parameters, CIMT or pulse wave velocity, are important prognostic and predictive factors. And these days, MRI is also used by the radio to assess the aortic distensibility. And this is the data from sprint test, which shows that those patients whose pulse wave velocity has decreased following NTI, which means you have two patients similar, say 160 by 100. In one, the pulse wave velocity decrease. This has a better outcome compared to the. So decrease in pulse wave velocity is a better predictor of a favorable response. I think brain and hypertension, all of us are aware of it, and not like to, and if you can evaluate the carotids or the body vessel by the carotid vascular ultrasound or by CT or MR angiograph or CT or MR in those patients who have developed strokes. Retinopathy, of course, is not our domain, so I'll not be touching, but it's important. You can see all physicians must also look at the fundus. So again, I like to reiterate, target organ damage involvement also remain silent for a very long time, and this slide gives wide dissemination. The problem with hypertension is not only the number of blood pressure which matters, the associated risk factors, the associated comorbidities are also important in determining the prognosis of the patient and initiating treatment. So to our patients, we give this mobile number for simplicity, 13080 10070, so they can see in the mobile. For blood pressure, there should be 130 for systolic, 80 for diastolic. For LDL, less than 100. These days, less than 70. For HbA1c, 7, and for smoking is 0. And this slide is dedicated to the President API Karnataka chapter, Dr. Murali. The treatment of hypertension is a long drawn process over the years, and therefore special emphasis should be laid on the quality of life. We must never forget our hypertensive patients not only live but also feel well, and this is very, very important. And most of the hypertensive patients are asymptomatic. It's very difficult to make an asymptomatic individual feel better. Usually is made worse. So very careful selection of drugs. I think that's all. Thank you very much for your kind attention.
Thank you, Dr. Manoria, for that wonderful deliberation on the way in which we evaluate the target organs and the implications of the presence of target organ damage, and what are the steps you would be considering in the managing these patients with the hypertension. May I request if the nephrology colleague of ours is free and to join?
I'd like to know this vascular calcification, which you commonly see, resistant hypertension, CKD. What is all this, and how can we tackle all this? Because we often hear from the nephrologist, we want to know preliminary information.
Sure, definitely. I think he must be available. In the meantime, Dr. Murali congratulates you from Bangalore, saying that it is an excellent presentation. I also felt so. Thank you so much. And
Dr. Kriplani sir is there. Is there?
Dr. Kriplani sir, please kindly join us and then start
your. He's there.
Yeah. Good evening, everyone. Thank you for inviting me. And it's a very big day when hypertension is remembered. It should be remembered every day. But I must congratulate the API Karnataka and the API team for putting this up, and two brilliant talks, both by Dr. Venkatram and Dr. Manoria, have highlighted the renal aspects. So they've made it easy for me to make comments. So to first answer the question that Professor Manoria has put about this calcification. You see, other than the usual cholesterol and lipid factors which affect the intima, we have factors other than that due to the hyperparathyroidism, which we call CKD, MBD, metabolic bone disease, and cardiac disease, where there is, because of the parathormone and calcium interactions and hyperparathyroidism, there is deposition of calcium extraosseously into the coronaries and all other vessels. And that type of coronary calcification is different. It is not only not in the intima, it is in the media and of the arteries, and it is long calcification. So our cardiology colleagues who do stenting and cardiology surgeons who do the bypass will tell us that is very difficult because the segments are long. They are not short nips as they are seen in the cardiac patient with no CKD, but with hyperlipidemia and pure hypertension. So the whole problem of restricting this calcification all over the body, including the radial, etc., when we try to put fistula, is dependent on how we manage the calcium part of the CKD MBD and respond by reducing the parathormone and keeping this extra osseous calcification under control. So it's very important for us to do that well, so that when the patient progressives, and that should be in CKD stage 3, A, B, and 4, because that is what progresses later and hampers the transplant and the looking after of the patient and causes premature death in the patients of CKD because of coronary artery disease. In fact, there is so much now emphasis on saving the patient's heart and not worrying too much about the kidneys. So if I may say, the new guidelines from our renal association, the KDIGO and the KDOKI, they are all focusing more on heart care rather than on kidney care. Now, Dr. Venkatram very nicely mentioned that the target for CKD is lower than the target for others. And somehow it has become a very important part to the nephrologist to protect the heart. So this 120 by 70 or 75, which is the target being invited as the better target, is not really to protect the heart. So Dr. Venkatram makes a very valid point that when you try to reach that target, the J-shaped curve does kick in, and many of the patients will lose GFR even in trying to protect the heart. And yet all the bodies who control nephrology are now accepting the cardiologist, especially because of the sprint trial. Now, the fallacy there is, and when we actually do it and try to reach 120, a lot of the patients who are not old, who are 50, 45, 60, waiting for transplants, they land up getting a rapid increase in the creatinine after we reach the target. So about this target, I would like to say that that target is valid as the sprint method. The sprint method used not the single office BP, but the what we call the BP true or the Omron 970, which measures out of office BP equivalent in the office. And this is very important. This is a unobserved method of tying the blood pressure instrument in a quiet room, checking the first reading by SSC or HSC qualified nurse who goes away, and then automated office BP, which was originally started in Canada and then has come on to this Omron 970, is a brilliant way of finding out a surrogate of the ABPM in the daytime. And many data have shown, because it's not possible. The gold standard is, of course, to do the ABPM, but it's not physically possible to do everybody's ABPM. But when the patient comes to office, one should remember that one office reading is useless. It has to be done in this unobserved method, automated, and get an average of 5 or 3, or now the MicroLife is being brought out an instrument which even can be used at home by the patient to get an average of 3 readings at half minute. And these are all being validated as being surrogates of the daytime average BP. And that is the target of 120 by 75, which these sprint are asking us to use. Of course, let me say there are big limitations to sprint findings, and more are being now becoming obvious that sprint sub-analysis has shown that the creatinines tend to increase when we go to this target. So we try to protect the heart, and we see little more rapid increase in creatinine, but we prevent the patient from dying from heart attacks due to this severe calcification of arteries. I hope that summarizes what you would like me to tell
Any
you.
drug for minimizing calcification?
Well, sir, drugs are plenty, but using the drugs like sinacalcet, which works on the calcium sensing receptors, these are now being used very well to protect and prevent these calcifications. But the most important thing is frequent checking and adjustment with alkaline phosphatase, bone alkaline phosphatase, and FGF23, which markers are still to be adopted so popularly because of their cost. And when these markers are adopted, we will get a better way of adjusting and getting the calcium to the target we want. And there are many pitfalls in that which I can't elaborate, but certainly those who see the patient frequently and keep a watch on the IPTH rather than the calcium, keeping the IPTH not normal value 75, but twice the normal, that is 150, is a good target. And keeping the calcium in ionized calcium form to about less than 5, between 4.5 to 5. These are the more useful targets which will help us with the use of calcitriol and sinacalcet to come into the mainstream management of these patients. And that protects the patient from heart disease and this very severe calcification which kills the patient. Also, the hypertension, which I didn't elaborate on, you have very nicely shown the hypertension as a cause of modulation of the LVH going on to concentrate LVH, then dilatation, then eccentric LVH, and then of course leaking valves. Once the valves start to leak, it's a terrible problem for our patients because they also need to go on dialysis. And from hypertension, they often go into hypotension. And there again, once these patients have such cardiac disease, they can't go on to transplant. They're not acceptable for transplant.
Thank you. Thank you so much, sir. In fact, I'm wondering if Dr. Upendra Kaur from Delhi has joined. Dr. Biradar, has he?
Not at joined, sir. He will be joining shortly if at all, if time permits. He is in other meeting. You can go ahead with the.
Yeah, okay.
That,
Okay. In fact, a couple of questions we have here from the audience. One important question from Dr. Meenakshi Sahapati. How significant is the finding of diastolic dysfunction grade 2 in asymptomatic hypertensive patients? Dr. Manoria, would like to comment on this?
Grade 1 in elderly patient may be treated as a normal phenomena, but
Yes.
grade 2 is not normal. Grade 2 is abnormal. Patient will have shortness of breath on exercise. You should treat it, whatever is the cause, hypertension being the commonest cause.
Fair. That's important consideration. Also, would you like to comment on this heart rate? How much do you think should be reduced to? And what is your ballpark figure? And how do you want to suggest monitoring for such patients?
There is ample evidence that increased heart rate is associated with increased morbidity and mortality. Even in controlled hypertensive, your heart rate is higher. Various trials have shown that you are at higher risk of cardiovascular events. But we do not have any randomized controlled trial which has shown that you decrease heart rate from 80 to 70, there's the benefit. So this is a desirable goal, but this is not a guideline-based recommendation. And if you are using beta blockers for hypertension or some of the coexisting abnormalities, the heart rate will automatically. But we don't have any guideline-based recommendation. The effect is definite and certain, but trial is yet lacking that you lower heart rate, you decrease all these events. That is the problem.
Okay, I want to ask you a practical question, sir. In case you want to add a first drug, will it be a beta blocker? If you want to add a second drug, will it be a beta blocker? If you want to add third drug, will it be a beta blocker? What is your personal approach?
All selection of all these 4 drugs which has come on number 1, it depends on the subset of the patient. We often find young individuals who have isolated systolic hypertension. They are usually IT workers. They don't sleep at night. It is beta blocker which control their hypertension. All these other drugs, RAS blockers or other diuretics don't control our blood. So all depends on the subset of patient. If it is an elderly, we like to use a calcium channel blocker and diuretics. In a younger patient, RAS blocker, and if necessary, a calcium channel blocker, or if there's some concomitant problem, even a beta blocker. So all depends on, there's no that this drug has to be used number 1, 2, or other so number 1. So it all depends on the subset of the patient.
Fair enough. So in other words, so when we are looking at the patient as a whole, we will have some fair idea how we would like to deal with the patient's opinion or other condition, and prescribe the drugs. Now, there was concern about the so-called office BP not being reflective of actual BP of the patient, and out of office blood pressure should be measured. What is your approach in your practice that you have been following? Just could you elaborate for the benefit of all the listeners, how you
Yes.
like to follow your patients?
So sometimes the office BP blood pressure may be higher than the home, what we term as white coat hypertension. Or paradoxically, the home BP may be higher and the office BP may be normal. And this we suspect, suppose somebody has a target organ damage and his blood pressure is normal in the office, what is termed as mask hypertension. That's why we say at least once in a time you should have a ambulatory BP monitoring, so that you can have a pattern of the hypertension, a circadian rhythm of the hypertension in that particular patient. Because if you are looking only at the office BP, you will be missing mask hypertension. So both these subsets, they demand either you solve this problem by repeated home blood pressure monitoring or by an ambulatory monitoring if possible. So that is important.
Yeah, in fact, we also have published this data when we measure the blood pressure out of office in a separate room in a quiet atmosphere that Dr. Kripalani was pointing out. There is something like a 20/10 drop of blood pressure within the next about half an hour or so when the patient is waiting in the waiting rooms. Do you recommend having such practices in India too, if it is possible?
Very difficult in the OPDs with so much rush. Very difficult to adopt this measuring blood pressure 3 times by the automatic and a separate room. I think very difficult practice because the number of patients are so many. But if there is a selected subset of patients, we can resort to it, but cannot be done for all. Difficult, at least in the OPDs.
At
Yes.
the moment,
Sir, may I say something, sir?
Yeah, go ahead. Go ahead, please.
See, the one that we use most is now the home BP. Educated patients, even uneducated patients, if we put enough effort into educating them, then a lot of of course, the nocturnal hypertension will not be visible. But the masked home hypertension will definitely be visible. And if we teach the patient to check twice a day, morning, the worst hypertension is just before waking up. So the morning, early morning, before he goes to toilet or after finishing comes back, first thing in the morning, check pressure. And again before sleeping, just twice. A fair idea comes, and we have some data of ours also, because that's the only real way to reach all the patients. Even keeping these instruments, which I have in my office all the time, is a specialized thing. It's difficult, it's no time, but as a specialized hypertension and CKD specialist, I think every CKD doctor, treating doctor of CKD patient, nephrologist, should have these instruments. As against that, a general practitioner can't have it. MD physician certainly should try to adopt if it's possible, but home BP is the way to go in these cases. And on a long term, with millions affected with a home BP, especially if you use the one which gives 3, average of 3, that MicroLife has got. It gives an excellent, within half a minute, you tell the patient, and it's much better. It picks up a smaller reading always. Sometimes, of course, it won't pick up masked hypertension. It won't pick up the night pressure. So for us, this is I think every nephrologist should do it. That's my answer.
A very profound, proponent of home blood pressure reading and out of office blood pressure reading being obtained in patients. And it is indeed a kind of a changing scenario in the next about few years' time. I think that practice should be percolating into the physicians' offices also, with physicians would be already crowded by consultation hours with quite a few patients. In other words, nurse educators or a technician sitting outside of the doctor's offices could also contribute to the care of the patient. While diabetologists do a good job, cardiologists seem to be still lacking behind it. In fact, no, it is a very interesting point for us to deliberate when we talk of home blood pressure reading. What should be the ideal readings of blood pressure? As Dr. Kriplani was mentioning, morning blood pressure as soon as the patient gets up. And the second blood pressure readings should be obtained just before the patient retires to the bed. And of course, 3 readings, some people recommend 2 readings, and the appropriate method should be adopted. I'm glad that that has been brought out. That is the only way to assess white coat hypertension as well as mass hypertension. That's what Dr. Manoria was mentioning about. If Dr. Kaul is there, because we are already kind of reaching the end of
no, sir, he has not yet joined. We can go ahead. Yeah.
Oh, okay. Any other parting message, Dr. Manoria, for the audience? Because we are left with 3 minutes now.
The message of World Heart Day is very, very clear. That has been repeatedly stressed.
Yes. Okay.
Dr. Manoria, may I also say that obstructive sleep apnea is a very big problem, and the more we correct it, the better it will be.
Yes.
I'm glad, very happy to kind of hear that comment from Dr. Kriplani again, indicating that sleep is an important part of the
and hypothyroidism
and also hypertension, where it
are very common causes.
Yes, one of the important causes of so-called secondary hypertension that we may often miss out in our busy practice.
Even aldosteronism.
Yeah. On behalf of the faculty.
So there is one question, Dr. M. Shankar Sharma wants to know what is your opinion regarding the electronic instrument versus mercury sphygmomanometer in a setup in our country.
Yeah. Dr. Manoria, please. What is your...
Mercury is banned. The way to record blood pressure is automatic BPM. Mercury is banned, although it's being used by physician. It's banned, no longer allowed.
Yes, it should be staying away from mercury instrument as much, and it is highly desirable that we should avoid using mercury in our offices.
So before you close, can I tell you something?
Yes.
One of my students practicing in Mofussil Place had a mercury instrument. His children picked it up and broke the tube on his bed without his knowing it. His wife cleaned it. 4 people got mercury poisoning, including the patient himself, the doctor himself. It is a documented case and he's going to publish it. Mercury is no more possible. It kills people. Luckily, they did the chelation and saved the 2 children. It was a critical problem. It happened in Maharashtra. It's a true story.
Oh, I'm very, very unfortunate. I am sure the advocacy of our mercury manometer being used in the office practice should be completely abandoned, and it should occur at the level of API, IMA, and the Indian practitioners in general. And the license should not be given to the people who manufacture, mercury apparatus. That's the one of the strongest advocacies that one can have on the mercury instrument for blood pressure measurement. Okay, with the permission of the faculty of the day, Dr. Manoria, Dr. Kriplani, and that was preceded by a brilliant talk by Dr. Venkatram, emphasizing the concepts of World Hypertension Day of the day, which suggests that we should measure the blood pressure, we should treat the blood pressure very adequately, so that we live longer, and we live longer, not just to live longer, but healthy life. That is the ultimate goal of our life indeed. And the points that were brought in by Dr. Manoria in terms of the organ evaluation and the options that we have in the management of hypertension, and important inputs given by Dr. Kriplani about the management of hypertension in CKD and the calcium management in the patients with CKD and its importance and its prognosis in the cardiovascular outcome are to be appreciated. Indeed, the questions from the audience were also very interesting, bringing out the facets of care of hypertension in the present scenario. Suffice to say that we should be staying away from mercury. We should be using the office blood pressure as much, and out of office blood pressure. And home blood pressure monitoring should be routinely recommended so that we get into the era quickly, which is contemporary already in the West. And while we select the patients, rather select the drugs for the patient, the drugs should be matched for the patient's requirement, as was emphasized by Dr. Manoria. Friends, we enjoyed both the talks and also critical comments by Dr. Kripalani. It is a pity that we could not get Dr. Kaul's inputs in this area, who has published on the heart rate evaluation in hypertension, published in CSI journal in our just about a couple of years ago. It could have been very interesting to listen to him. Suffice to say that we had a very fruitful day, and may I thank the organizers for providing this opportunity for all of us, especially for me. I always look forward to be associated with API crowd, because that gives us the real taste of medicine for cardiologists, because cardiologists seem to be sometimes cocooned into their practices. Thank you so much for the kind attention, and thank you one and all. Back to Dr. Biradar, please.
Thank you, sir. Thank you for that wonderful moderation, and I thank all the speakers and the faculty. Before Dr. Vishwanath proposes a vote of thanks, I request Dr. Vishwanath to propose a vote of thanks. Kindly unmute and speak. You are not audible, Vishwanath.
Yeah, now you're audible.
Yeah, sorry. Good evening, sir. Thank you one and all for this excellent session. To begin with, all the speakers, Dr. Professor Venkatram, an excellent lecture. Dr. Manoria, sir, a brilliant lecture. Lot of valuable take-home messages, simple things like LVH with dilatation, LVH with fibrosis, flow velocities. These are the things which really help physicians a lot, I feel. I think thank you for that excellent lecture. And Dr. Kuplani, sir, also thank you very much for your inputs. And as usual, a very crisp and great moderation from Dr. Nagaraj Desai, sir. I also thank my chairman, API, and Dr. Biradar, sir, for bringing all these expertise and giving us valuable inputs to all the attendees. Thank you, all the delegates. Thanks also. Thank you.
Thank you, sir. Thank you, one and all. We sign off. Thank you, Dr. Kriplani, Dr. Manoria, sir.
Good night. Good night. Thank you.
Thank you, sir.
Thank you all. Bye-bye. Good night. Good night, sirs.
Good night,
Night,
sir.
everyone.